Good morning, everyone. Welcome to Grand Rounds. Dr. Kassam is away today, so I have the privilege of moderating Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose languages and cultures continue to enrich our vibrant community. Today, I'm very pleased to introduce two speakers. They will be presenting on safer supply and political interference in medical practice, Alberta's Narcotics Transition Services. First, Dr. Elaine Hyshka. Dr. Elaine Hyshka is an associate professor and Canadian Research Chair in Health Systems Innovation at the University of Alberta School of Public Health and Scientific Director of the Inner City and Wellness Program. Her program of health systems and services research is focused on advancing a public health approach to substance use in Canada. Dr. Hyshka previously served as co-chair of Health Canada's Expert Advisory Group on Safer Supply and co-chair of the Provincial Minister of Health's Opioid Emergency Response Commission. I'd also like to introduce Patty Willson, who is a primary care nurse practitioner and works in Calgary, Alberta. Her clinical experience includes outreach harm reduction settings, medical withdrawal management, opioid agonist therapy, including injectable opioid agonists. She completed an addictions fellowship in 2021 through the through the BC Centre of Substance Use and focused on program development and advocacy. So please welcome Dr. Hyshka and Patty Willson.
Thank you. Good morning, and thank you for being here today. We're really excited to be presenting on this important and timely topic. So before I get started, I thank you, Dr. Ringrose, for that land acknowledgement. I do want to acknowledge that anytime we're talking about the topic of drug poisoning, substance use, and related morbidity and mortality, it's really important to recognize the disproportionate impact experienced by Indigenous peoples in Canada. So we must acknowledge the contributions of colonial violence and land dispossession to the current epidemic and the disproportionate impact of drug prohibition on Indigenous peoples. Ameliorating these harms will require a commitment to honoring the TRC Commission's of Canada's calls to action and support of human rights and health-based approaches to substance use. So not much for disclosures. Both Patty and I have accepted travel costs to be invited speakers at the National Safer Supply Community Practice. I've had peer-reviewed research grants studying safer supply, as well as served in a few unpaid advisory positions to government. So our talk today is based on a policy commentary that we published as part of a special issue on safer supply in the International Journal of Drug Policy. So if you have an interest in this topic, I encourage you to check out this issue. It has a lot of research from Canada and was led by Canadians. And if you want more information on what we're presenting today, it's also in this paper. So just for a bit of an overview, we'll go through Canada's current toxic drug crisis, including discussing some of the factors that led to the current situation. And then we'll go over prescribed safer supply as one response to the toxic drug crisis. And then we'll discuss how safer supply has been regulated in Alberta. So since 2016, over 50,000 Canadians have died from drug poisoning. In Alberta, that number is over 10,000 people that have died since 2016. And to put that number in perspective, that's well over 3,000 more people than have died from the COVID-19 pandemic in the province. So when we talk about drug poisoning deaths, it's important to recognize who's most at risk. So we know that in Alberta, 71% of deaths are amongst males. The age range tends to be between 30 and 44 years old. And typically in the circumstances of death, 75% are using alone. And it's also important to note that a lot of attention is given to opioids in this crisis, but really what we're dealing with is a polysubstance use issue. Most opioids are contaminated with other substances, or are often contaminated with other substances, such as benzodiazepines and tranquilizers. And as well, we're seeing an increasing trend of stimulant co-use. So for example, in Alberta last year, over 60% of opioid-related deaths also involved methamphetamine. So It's important to recognize that the harms of drug poisoning and toxic drugs are not equitably distributed across the population. And in particular, in Alberta, First Nations people are at significantly greater risk than members of the general population. In fact, their death rate is 8 times higher. And this disparity reflects the impacts of colonial violence, racism, discrimination, and multi-generational trauma. As a result, this disparity has contributed to an 8-year decline in life expectancy for First Nations people in Alberta, and their life expectancy is currently the lowest since we started collecting and recording this data. So how did we get here? When we talk about the toxic drug crisis and understanding solutions to addressing it, it's very important to understand some of the factors that led to the current situation, because that's how we can start to devise solutions to address it. So contrary to common perceptions, drug poisoning mortality is not increasing. Drug poisoning mortality is not increasing because of an increase in the prevalence of drug use disorders. So often we hear in the media, oh, we have an addiction crisis, or oh, addictions have skyrocketed and all these people are now dying from drug poisoning. We actually don't have data to support that hypothesis. The data we do have suggests that the rate or prevalence of drug use disorders in Canada has been relatively stable over the past decade. And this slide just shows some cross-sectional data from Statistics Canada. So instead of demand factors, evidence is really coalesced around the fact that supply side changes are really what's causing the current spike in mortality and morbidity that we're seeing. So we all know the story. Back in the 2000s, there was aggressive marketing and weak regulation of opioid prescribing, and that led to significant diversion and non-medical use. By 2010, 1 in 20 adults and 1 in 6 adolescents in Canada were reporting using prescription opioids non-medically in the past year. And increases in opioid-related morbidity and mortality were observed across multiple provinces. So growing concern about this situation led to several different efforts on the part of decision makers and regulators to constrain opioid prescribing in Canada. And you can see that many jurisdictions across the country did in fact significantly reduce the amount of opioids being dispensed in their provinces. So in Alberta, for example, you can see the population level flow of prescription opioids here actually was halved by about 2019 or 2020. However, mortality did not decline with those efforts. In fact, it significantly increased. And that's because the illegal drug market innovated to meet the demand that went unmet by the constraining of prescription opioids. And so the illegal market responded with mass producing and distributing fentanyl and other novel synthetic opioids that are illegally produced and then distributed. And this slide just shows you, in particular, Ontario, Alberta, and BC have had a significant increase in fentanyl identifications by the Health Canada's drug poison or DAS lab. And so here's the data. If you look back 2011, that was about the height of what we were calling then a prescription opioid crisis. And we had about 100 people dying from drug poisoning in the province that year. Since then, the numbers have increased exponentially to height in 2020 or 2023 to just under 2,000. So really, this shift in fentanyl or towards fentanyl and away from prescription opioids has resulted in the drug supply becoming much more unpredictable and dangerous. So because of novel synthetic opioids, people don't know what they're taking. It's very difficult for them to know how potent the substance they're consuming. And really it can vary from batch to batch and dose to dose. So in that context, it's very difficult to not have a drug poisoning. In responding to the epidemic, obviously there's a lot of different strategies we can use. And one that has emerged is prescribed safer supply. And so we're just going to discuss that now as part of one component of a public health response. Okay, so obviously the increase in mortality has been significant. Public health officials across the country are, strategizing ways to respond. And the public health response to date, and really even currently, consists primarily of focusing on a few sets of interventions that really are targeting either the host or the environment. So this is the epidemiological triangle. It's an established way of formulating public health responses to population health threats. And you can see that most of our efforts today are really focused on either changing something about the environment, so the environment in which drug use is occurring. So that includes things like supervised consumption sites where people can go to use and then receive emergency medical care instantly if they have a drug poisoning. Naloxone kits and bystander training on how to respond to drug poisoning. The Good Samaritan Drug Overdose Act is legislation that provides some limited immunity for bystanders and people at the scene of a drug poisoning. And then, of course, a lot of effort has been made to try and change the behavior of people who use drugs through safer drug use education, through provision of opioid agonist treatment, having people abstain from illegal drug use. Drug checking programs that let you know what's in the substances you're taking are somewhat available in different parts of the country. Public awareness, and then harm reduction, supply distribution. However, very little attention has been paid to the agent or trying to address the most proximal factor to drug poisoning, which is the toxic drugs themselves. And so that's where safer supply emerged as an innovation to try to prevent morbidity and mortality amongst people who are using and dependent on primarily the street supply of opioids. So there's many models for safer supply, and they've been implemented in multiple provinces across the country, but the most common is to embed it within primary care. And it typically consists of short-acting opioids prescribed very commonly alongside opioid agonists, more conventional opioid agonist treatment. And typically it's daily dispensed dosing that is unwitnessed, and it's provided to someone to take as needed throughout the day, how they prefer to take it. And then it often includes as well witnessed opioid agonist treatment at the pharmacy. And so the intent of safer supply programs is to reduce people's reliance on having to purchase illegal street opioids that are often highly potent, contaminated with benzodiazepines or tranquilizers, and really just make reduce some of the risks associated with ongoing illegal drug use. And so, of course, as part of these are medical programs, so they're often, treatment is available and encouraged for people, but we do recognize that not everybody is able to start treatment right away. And this is one strategy to try to reduce risk amongst a subset of people who are continuing to use and experiencing harm from that use. So the evidence on this strategy is quite emergent still. We've really only had examples of these programs in Canada on a kind of a larger scale for the past three or 4 years. Yeah. Maybe 5 years now. I'm losing track. And so, of course, evaluations take time, but the data is starting to accumulate. And we do have some pretty good quality evidence from cohort studies that analyze administrative health data that have shown declining drug poisoning and mortality risk associated with when people are receiving safer supply dosing. So, for example, this one study on just the one with the blue heading, that's from our colleagues in BC, and they analyzed the risk of mortality associated with dispensing of what they call risk mitigation, but essentially primarily short-acting hydromorphone. And they found a dose-response relationship associated with or between having a dose and then having a decreased risk of mortality in the week preceding. This new study just came out last week, I think 2 weeks ago. It's on your left, and that's from colleagues in Ontario. And their research has demonstrated that people who they can compare a cohort of people that were starting methadone versus a cohort that were starting prescribed safer supply. And they found pretty similar outcomes overall. Methadone outcomes were a little bit better. However, they found better retention amongst patients that were being prescribed safer supply. So essentially, there is some evidence to suggest that these programs have a role to play in reducing the risk of death for the patients that are accessing them, and they may be one component of a public health strategy, although further evidence is needed to assess benefit as well as potentially unintended harm. And now I'll turn it over to Patty.
Great, thank you. So I'm going to be taking you guys through what did safer supply in Alberta look like and what are some significant changes to that. Just a brief timeline to understand what that political acceptance of safer supply in Alberta was like. In 2018, safer supply was endorsed nominally by the NDP, but there was no real support to implement it. In 2019, the UCP were elected, and this represented a shift away from harm reduction and towards the UCP's recovery-oriented system of care. In Canada, in 2019, there were federal grants that were released for people who were wanting to start up programs that were wanting to start their own safer supply program. There were no formal programs in Alberta that were able to take advantage of any of these grants. However, in 2020, we saw a large increase across Canada in safer supply programs, but not in Alberta. Despite no formal program, some people were able to incorporate safer supply into their primary care and addiction practice. Notably, in 2021, one group did apply for a safer supply federal grant, but they were pressured to cancel this grant, and so we don't have any programs. And then at the end of 2021, there was the motion to strike a bipartisan special select committee to examine safe supply. And so this committee, its mandate was to examine the concept, evidence, and the impact of safer supply. Initially, it was UCP and NDP MLAs. However, the NDP left after 2 sessions due to concerns about the witnesses that were put forward, who many had previously expressed anti-safer supply opinions. And there was concern that this would be a very biased committee. And so the NDP stepped away. Notably, among the witnesses, there were no safer supply clinicians, researchers, or people with living and lived experience of safer supply. As part of the committee's work, they commissioned a literature review. This literature review was not peer-reviewed. The BC Centre on Substance Use released a letter outlining their concerns about this literature review, and independent researchers critically appraised literature review, and they determined it was critically low quality. Primarily, they seemed to focus on the search strategy. It was inappropriate, and so they missed key articles and included other irrelevant, articles. And so this is a timeline of the committee's work. So it was struck in December 2021. After 2 sessions, the NDP left that committee in February, and then the final report was done in June. Very shortly after that, the government of Alberta announced that they would be ending safer supply in Alberta. And then that change in regulations came into place in March in 2023. These are some of the recommendations from the committee's final report. I'm just going to highlight a few things here. One, there was a real emphasis within the committee's work that safer supply, that as it existed prior to March 2023, didn't have a lot of medical supervision or oversight. This is false. However, the final report did say that safer supply could exist within strict medical in-clinic supervision. Notably, I've highlighted a few words here that to me really help paint the picture of the narrative that was being shaped by the committee with regards to safer supply, noting that the government has to take the necessary steps because there were harmful pharmaceutical practices that were occurring, and this was leading to community diversion and increased addiction and increased overdose. Again, this is not the case. However, we start to see this sort of narrative of leaning on that history of overprescribing chronic opioids for pain and continuing that narrative to current date, even though the drug supplies are vastly different and the death rate is overwhelmingly attributable to fentanyl. And lastly, I think the last one also talks about, I think it really highlights the degree of control that the government was hoping to enact, including stepping into medical education in order to make sure that prescribers are prescribing things safely with the underlying assumption with that existing practices were not safe. So I'm going to dive a little bit more into some of the political narratives now that were enacted within the committee. So first, we've already spoken about this a bit, but the idea of addiction crisis versus toxic drug crisis. We are in a toxic drug crisis. It is fentanyl that is killing people. Prescribed opioids make up a very small proportion of the deaths. But by framing it as an addiction crisis that comes from prescribed opioids, it is placing prescribers in the role of villains as a result of that. It justifies restrictions and also government overreach in order to control that addiction crisis that is being perpetuated by prescribers. So not only does this negatively characterize safer supply prescribers as reckless and unethical, it also helps support regulations that would come into place. I also want to take a second to talk about how recipients of prescribed safer supply were framed. They were framed as almost always intending to divert their safer supply medication, and that was leading to these community-wide increases in addiction and death. It's important to note that safer supply, and when it was being dispensed within the community program before the regulation change, the graph on the right shows the count of people receiving safer supply during that time, during the committee's work, and then starting in 2020 as well. We can see the maximum number of patients is 246. On the left, we see chronic pain, hydromorphone, prescribing in the tens of thousands during that time as well. And so by targeting safer supply recipients as people who are responsible for an addiction public health crisis, it vilifies these folks. Not only their numbers do not bear that out, but also in addition to that, it paints them as nefarious because they're always going to divert their medication and ignores the realities of why diversion does occur as well, which is very complex. So in March 2023, community safer supply programs ended, and we have the introduction of the Narcotic Transition Services, or NTS. Under this, short-acting opioids are only allowed at NTS sites, and there are 6 locations within Alberta only versus community pharmacies, which potentially all could dispense safer or short-acting opioids. These changes, they require witness ingestion at one of the 6 locations, and this includes mouth checks for clients as well. Any healthcare provider that's found in violation of these new rules faces a $10,000 a day fine for each day that they are found breaking these rules, up to a maximum of $100,000. Okay. And I wanted to take a second to really highlight, once I find my spot, to really highlight the community protection opioid stewardship standards. Found it. So these standards are what guide the NTS clinics, and they set a minimum requirement for this. So at minimum, NTS clinics must meet this. I want to highlight that this is a very laborious set of standards that are required. And again, if you're found in violation for not meeting these standards, there's a $10,000 a day fine for that. Some highlights from that. So there's extensive procedural requirements, including a 4-step consent process, strict timelines on certain assessments and approvals down to like the hour of when this must occur. This also lacks a real safe approach to substance use care. 2 things that I want to highlight. There is the best efforts to transition subsection. This tells, within these standards, it says that folks who are admitted to NTS, as soon as possible, they have to transition back to OAT, opiate agonist treatment, alone. However, one of the eligibility criteria in order to become a patient at NTS is to fail to stabilize on traditional OAT, or opiate agonist treatment. So you have this scenario where people have failed one treatment, transition to short-acting opioids, only to be transitioned back to OAT as soon as possible, a treatment they have previously failed. Additionally, patients are discharged from these clinics if there are 30 days of them not attending. This is notable because this would impact people who are in corrections or in treatment centers. And the highest risk of overdose in terms of people moving through the system is 2 weeks after people leave jail. That is the highest they will ever be at risk of overdose. And this is also, under these new regulations, the time when they will have access to less therapy and less medication than before they went into corrections. This also, because the standardized are so prescriptive, they remove a lot of prescriber discretion in this as well. There are incredibly strict eligibility criteria. It severely restricts the role of the nurse practitioner, and certain opioids are used only as a last resort. With a slightly better understanding of what these regulations are, what is the impact to patients with this? So before NTS was implemented, people could dose their short-acting opioids close to home. They could go to their community pharmacy, pick up their safer supply medication, use it throughout the day the way that they wanted to. They can also decide when and how to take it. So if it's the middle of the night, they have that option. They can also remain with the community prescriber. Importantly, that is also, importantly also, they can remain on short-acting opioids for as long as it's beneficial to them. For a hospital setting, they can also be admitted for stabilization of their opioid use disorder. Since the regulations have come into place, clients now must dose at an NTS clinic. It must be witness dosing, and it can only occur during operating hours. So those middle of the night dosing, if that was a reality for some folks, is gone. Also, due to the high demand on patients to attend the clinic multiple times a day for their dosing, all of their care or most of their care would move to these NTS clinics as well, because this is such a time, this takes up such a considerable amount of clients' time. And then again, that best effort to transition. So OAT is prioritized. There's a few specific hospital-related factors that I'm going to go to in the next slide. So when can short-acting opioids for opioid dependency be prescribed in hospital? The criteria is limited and a little bit vague as well. Patients who are admitted to hospital, and they have to have admission for another indication other than opioid use disorder. So this could include a medical condition or a psychiatric diagnosis, however, not opioid use disorder. They're not allowed to be admitted for opioid use disorder alone. They cannot be admitted for psychosocial factors. And if a patient comes into the hospital from an overdose, they must have some other comorbidity in order for them to be able to receive short-acting opioids. This really, in addition to being very vague and confusing, it sort of is trying to get it's trying to get around a diagnosis of people being admitted for opioid use disorder, where short-acting opioids would not be allowed, versus admitted while experiencing opioid use disorder, and then sometimes that is permitted. So impact on people who are on safer supply before this transition. There's no public reporting of these outcomes. We do know approximately 350 patients were impacted, but we don't know if their outcomes are tracked and what happened to these folks and how many were able to transition to NTS clinics. There are reports from healthcare providers during this time that talk about a breakdown in therapeutic relationships they had with their patients, a decline in patient health, and significant moral distress for the healthcare providers. So while we do not have any publicly available outcome data on these patients who had to transition, we do know from research that opioid deprescribing, especially in a forced taper, as this would have been for many people, is incredibly harmful. It increases overdoses, it increases mental health crises, and it will increase hospitalizations as well. One patient who was not able to transition to the NTS clinics, I want to say a little bit more about her. So this is Ophelia. She had been started on short-acting opioids or prescribed safer supply in 2021. Prior to that, she had gone through a few trials of different OAT, but had not been able to stabilize. Once she started on hydromorphone tablets, she stopped her stimulant use and her health began to improve. During her time on prescribed safer supply, she had one overdose, and this was when she was not able to access short-acting opioids. The change in regulations, the way this would have impacted her because of where she lives relative to the NTS clinic in her area, would have required 4 hours of daily travel, and she wouldn't have been able to receive all of her doses because one of her doses was after the clinic hours. So she filed an injunction in order to continue to access safer supply in her community and at her home pharmacy, and she was successful because the judge found that she was at high risk of harm, very likely to have high risk of harm, and that this was an infringement on her constitutional rights. And then the impact on healthcare providers. These new standards are burdensome and very confusing. There is a high volume of administrative obligations within the context of a health system that is not properly resourced to respond to this public health crisis. The rules are incredibly strict, and it creates liabilities that are often not feasible to implement. And because they are so confusing, this might result in a delay or denial of care. When these regulations were implemented, the communication was incredibly poor, and it was the rollout was very, very unclear for many people who would have been impacted for this. Very likely, this resulted in unintentional non-compliance by some prescribers. Because of this fear of professional discipline, the significant financial penalties, this also means that people are going to hesitate to reach for short-acting opioids, even when they are permissible within the new regulations. Importantly, too, these changes are ideologically driven. The committee did not establish that there is any current harm to the prior model of safer supply. And so this puts prescribers in a position of having to follow policy that is based on ideology and not evidence. It undermines a healthcare provider's ability to practice on best available evidence. It infringes on clinical discretion because the standards are so prescriptive, and our ability to provide patient-centered care is very limited in these circumstances. These are also widespread restrictions as well, and they've been imposed on medical practice without proper evidence or debate. And the scope of practice is curtailed based on these restrictions, and it's based on ideology rather than evidence of harm. Ethically, this puts prescribers in a position of needing to follow these mandates and these regulations, which conflict with best available evidence and evidence of harm, and it creates a real ethical dilemma for prescribers. And so just to bring this back a little bit, I want to again highlight that prescribers within the committee's work were painted as often reckless and enablers. The history of overprescribing chronic opioid pains was invoked quite a bit. And so we're framing prescribers as a really harmful group. And then at the same time, the fix to that apparently is to introduce a set of rules that are very convoluted, divorced from the realities of clinical practice, that even making it so that even the most careful prescribers are likely to violate these regulations. And this impacts not just prescribing, but also substance use care and research generally. This limits not only how we prescribe, but how we respond. We are in a poly-substance use drug supply, and yet we are limited to 3 opioid agonist medications. Since the regulations have been produced, the drug supply has only become more volatile. And this approach of over-restrictive, prescriptive, and limited scope on our practice prevents real-world evidence building in the midst of an urgent public health crisis.
Thanks, Patty. All right, so just to conclude, I want to be clear, I think both of us agree that it's very important to have robust professional debates about what is the evidence, what are the needs of patients, what are the ethics of emerging practices in controversial areas of healthcare. However, when we see political interference and political elected officials setting, interfering and setting highly prescriptive standards, that is limiting our ability to do that. So when we talk about medicine in general, we have self-regulated professions, right? And that is based on the idea that people who study and learn medicine and do the research are best positioned to decide on what is safe and effective practice. But really, when we have governments overstepping and setting very prescriptive standards and rules that impede on medical practice and impede on the self-governing function of professions, it's not in the interest of patients, and it's certainly not in the interest of clinicians or scientific research. However, we are seeing this as an increasing trend, not just in our area, substance use, which has always been controversial to some degree because of, it's kind of a morality policy area. We're also seeing in other areas like in trans health, as well as even in scientific research more generally. Last year, the government passed Bill 18, which does enable the provincial government to veto tri-council grant agreements for individual research projects, should they choose to do that. So in that context, it's very difficult to study a very complex and difficult to address public health problem like the toxic drug crisis, because we have limited ability to innovate, to evaluate these innovations, and then to scale and spread them, certainly around safer supply, but also potentially around other healthcare practices. So even if you don't work in substance use, or you don't think you'll ever treat a patient that has a substance use disorder, this is important for you because, it's substance use today, it's trans health today, it's abortion and sexual health today, but it could very well be another area of medical practice tomorrow. And so really, as a profession, I do think, and as scientists, it's really important that we defend the core self-governing features of medicine and of academics and scientific research, because really, it's just doing a disservice to population health when we can't ask tough questions and study them and figure out what is going to be the most effective solution to the whole host of health and social problems that we are currently facing. So I think we'll leave it there. And we wanted to leave some time for questions. We know this is a complex area and we figured there might be some. But I just want to acknowledge as well our co-author, Dr. Kate Kaliza, who was not able to join us today, who contributed to this work and the manuscript. When Alberta made their policy changes around the NTS, they were so novel in Canada and really frankly internationally that KD, the Canadian Treatment Info Exchange on HIV/AIDS, actually came to Alberta and made a documentary about these changes and some of the impacts. And Patty was in that documentary as well as some of our other colleagues. So if you want to learn more about this topic, I encourage you to also check out this documentary, which might be a little more engaging than reading our manuscript, but just by a little. Okay, so thank you very much.
Thank you so much for such a great thought-provoking talk. Any questions in the audience? Yeah.
Really appreciate the thoughtfulness and the approach. I'm interested in how you would gain the attention of the people who are changing things, because they really don't care about our time. And so what is the approach you would propose to change their hearts? Because you have to change their hearts first.
I think that's a great question. So the question is around how do you get the attention of decision makers and also influence their thinking on these topics, like shifting their minds and their hearts. So it is hard, and this is a difficult time. 2 points I would say is the first is drug policy is my area, and I'm very passionate about this. I've been studying it for a long time now. And so it's always hard to change policy in this area because it is morally contentious, because we are all socialized around certain norms related to substance use that are difficult to unlearn. Often evidence base is not well understood. But what I find really effective is to have the voices of lived experience be front and center. So as much as we can empower patients as well as their families to share their stories and their truth. Like I think when you look at Ophelia's case, for example, Ophelia Black in Calgary, who is involved in this charter challenge, it's much easier to understand the concept of safer supply and why it might be beneficial for a subset of people when you can hear how it impacted her. And that is, an N of one. And of course, as scientists, we want to study and understand both individual and aggregate harms and risks. But I think it's a really important piece of advocacy is to have those stories, because it really does make the issue concrete for people. And it's not just this, abstract population in the background, but it's actually like a real person in front of you. The second thing I want to highlight for Alberta in particular, my colleague, Dr. Jared Wesley, in political science here, he does some really excellent research on public opinion polling. Mm-hmm. And what he finds consistently is that there is a divorce or a gap between what Albertans think, but what they think the rest of us think. So to put that in perspective, if you ask people in public opinion surveys in Alberta, like how many of you support supervised consumption services, a plurality support supervised consumption services, even though in the media you see like lots of backlash and lots of loud voices opposing them. If you ask Albertans, most people in the survey say they support them.
Mhm.
However, if you ask Albertans how many people in Alberta support supervised consumption sites, they'll say around 25, 27%. So we are consistently underestimating public support for very like evidence-based, like mainstream kind of pragmatic approaches to addressing complex health issues. And so part of our challenge in Alberta is also helping people understand that you're actually not the minority. Like you're often not the minority on these issues, even with stuff related to like transitioning away from oil and gas. The level of public support is much higher than you would believe by just reading the media or what our elected officials are telling us. So that's another thing I think we have to work on. And so I do think this kind of like public opinion polling, having town halls, hearing from more voices and having reasonable discussions, I think is a way. It's a slow way, but it is something that's necessary, I think, to get us out of this kind of like entrenched and polarized environment that we're currently experiencing.
May I ask a follow-up to that?
Mhm.
In these voices, and you gave the example of suing the government to obtain safer supply. There's our Indigenous population is disproportionately affected.
Mhm.
How do we hear those voices that don't have the means or perhaps the organization to share their
Mhm.
voice?
Yeah, that's a great question. And Patty, I don't know if you want to add, but like for us, at least with the research program that we're doing, we do have a longstanding community advisory group that is comprised of over half. It was about 14 people, and over half of them identify as Indigenous. And what we have been doing within our program is finding opportunities for them to participate in direct advocacy and stakeholder relations with government. So, for example, you may have seen last year and this year, the city of Edmonton was debating a public spaces bylaw that at the time was proposing quite significant fines for public drug use. I think it was like $500. So when that was tabled, we actually connected with the mayor and 3 councillors and had our community advisory group go to City Hall, sit in the councillors' boardroom and explain to them why these fines were counterproductive, why they weren't going to deter drug use, and why they were just going to make it harder for people to access the help and services that they need. And so we try to do that as best we can. I think also building coalitions across different issues. Like we focus a lot on substance use, but obviously it's part of a much broader picture around structural vulnerability, so like poverty, unstable housing, houselessness. So trying to build coalitions across issues, I think is also really important for having diverse voices heard and showing kind of critical mass for support for some of these policy changes. I don't know if you want to.
Yeah, I don't know that I would add. I don't know that I would add much to that. I'm not a researcher. I'm a clinician, and so it's sometimes a little bit harder to understand how that would look in your own practice, your one-on-one practice with patients. I try to use the privilege I know that I have as a prescriber, as somebody who has professional designation, and that sort of that allows me a certain amount of privilege to, as much as I do not enjoy speaking to media, speak to media when I can. Make sure the message that I am speaking to is very clear. And as much as we love nuance in research, trying to clean up that message a little bit so it's understandable to a general public. And then asking media if they, when I am speaking with them, if they have spoken to somebody who has that lived experience and who else they are speaking to. And if it is very obvious that there are important voices missing, connecting them with those voices.
Thank you.
Sorry.
You're next.
What is actually happening across Canada with this, and we use that as leverage?
Okay, you know the nationals. Yeah, I think like I'll let Patty take it, but we are seeing a similar trend of backlash. Do you want to?
Yeah, so in BC in February, so BC is the province who has the highest number of clients on safer supply. That being said, it's still less than 5% of people who are eligible as per their criteria. So it's still a small number. But BC decided to change over to witness dosing of safer supply at the pharmacy. Diversion was also used as a reason for this, again, despite lack of evidence related to that. That is still being rolled out right now. I think we're seeing what that would look like. It does potentially mean deprescribing on for hundreds and hundreds of people there. In terms of using it, I think we've been talking about this for a while, trying to say that what's happening here in Alberta is going to happen in other provinces. And I think we're seeing folks start to really understand what that means. And they're starting to, I've even had conversations about our Compassionate Intervention Act and understanding what exactly that means and what that will look like for their province. The way I try to use that is I try to speak about, again, as much as I can about these topics and what I'm seeing here in my experience and the harms that are being done, and what has been effective here. So, you know, it's a court challenge is very, very hard. It's very long. It's not going to have an immediate effect, but that also can be effective because then it becomes case law, and that has been used in Ontario in order to help keep some safe supervised consumption sites open. So it is still important, even though it is long.
Yeah, like the decision in the Black case, which is just an injunction decision, so the trial is still pending, was actually used as a precedent in Ontario to oppose the government's closure of some of the supervised consumption sites there. The reality is we are seeing a very organized opposition to progressive drug policy and harm reduction across the country, and it's being driven primarily by right-wing populist movements. And that's not unique to Canada. We're seeing that in the United States too. And so it is kind of a dismal time for nuanced discussion and evidence-based practice in this space. The reality is, I think also what we're having to do now is study some of the impacts of these changes to have the evidence to show what the outcomes are. So I was on a submission that's under review in Ontario where they're trying to study the withdrawal of these programs as well as some of the supervised consumption sites. But yeah, it's challenging. I want to be clear about diversion too. Like there has been anecdotal reports of diversion. There has been some police forces have said they've determined that some people were selling their prescriptions. But what we don't have is any evidence that that diversion is contributing to harm, including increases in mortality. And we also don't really have evidence to show that the majority of diverted pharmaceuticals that are circulating in Canada are coming from safer supply. It's very likely that's not the case, but just given the small scale. So it is a legitimate concern as a public health person. Like I don't want to unintentionally cause harm across the population, by a new intervention. But again, when we can't implement these on smaller scales, study and evaluate them and assess for harm, we also are just stagnating in our practice, and we are sitting with a host of interventions we have to address drug poisoning that are simply not enough to bring down morbidity and mortality to where we need to be. And so that's, I think, what's really frustrating is, everyone in population health and in medicine, we don't want to cause harm. We want to, assess meaningfully what's going to work and what's not going to work for who and where and when. But we just can't do that. And I think that's causing a lot of moral distress, more the removed people, like the population health people, but also certainly on the front lines.
Thanks for the talk today. Really important talk, or excellent talk and important talk. So you alluded to the agent and as the positive thing, in particular the fentanyl that's now coming used illegally and such. And it sounds like safer supply is the correct way to address that issue. But in the context of just fentanyl, I'd be interested in hearing your thoughts about what else can be done to address the supply of fentanyl and other substances.
Yeah, that's a great question. I think, the way safer supply was implemented was really a very medical model, right? Like there's other models. For example, one in BC, that's also before the courts, was a buyer's club where people were purchasing drugs off the dark web using a mass spectrometer to test them. So they were of known contents and composition, and then selling them at a cost recovery basis to a select group of people that had very high risk of drug poisoning. These kinds of approaches, I think, have a role. Beyond that, I think we need to be asking what the evidence is for some of the stuff we are investing in. So, for example, Alberta has gone and invested hundreds of millions of dollars in new residential treatment programs, but we don't have any evidence on how many people are going to those programs, what the case mix is of the patients that attend there, how many complete, what the impacts are in terms of, achieving abstinence and recovery, as well as what are potentially some of the unintended harms. So I do think, I know it's not a satisfactory answer, but we should certainly be evaluating those investments too, and not just assuming that because they're treatment, they're beneficial. Yeah, I don't know. Do you have any?
Yeah, I was just gonna add that we know that substance use doesn't occur in a vacuum. It's not something that just people do on their own. So looking and understanding the reason that people use drugs. Sometimes it's recreational, sometimes it's euphoria, sometimes it's people need to stay awake for the entire night for their safety, sometimes they have unmanaged pain or trauma. Yeah, and addressing those reasons. We're in an affordable housing crisis. It's hard to be well if you're not housed. And addressing that's also much more complex and not an easy answer, but addressing those unmet needs are really important too.
And prevention. No one, like, it's so funny. We have a recovery-oriented system of care, but no one here talks about actually preventing, like meaningful investments in prevention that will support young people to delay onset of substance use if they are going to use, or to avoid it, find other forms of leisure, address underlying mental health that may be triggering people to use. Like, we really aren't talking about that at all. And so if we're not going to talk about harm reduction right now, then at least let's talk about evidence-based prevention and evidence-based treatment and make sure that those systems are as high quality as possible, and really are world leading. And we are not there in Alberta or really anywhere in Canada.
I have a couple questions online. We addressed one of them. There's one asking about this presentation. Is it ideologically biased with a pro-NDP political position?
That's a good question.
So just wondering if you could comment on
Sure.
that.
Speaking for myself,
Sure.
I'm not a member of a political party. I encourage citizens to be involved in the political process. I think it's very critical. Me personally, I do not engage because my main motivator is to reduce drug morbidity and mortality. Like, that is what animates my career. I will work with any government that wants to address those issues in a meaningful way. That being said, I also think it's important to just I was actually one of the people that was asked to be a witness before the Safer Supply Committee. The opposition had nominated me because I work in this area. At the time, I was co-chairing Health Canada's expert advisory committee on the topic. But I made a difficult decision to decline because I didn't want to be part of a process that I felt was set up to fail from the start. And I didn't want to my participation would legitimize essentially what was an effort to manufacture evidence against a controversial intervention that was still being tested. And I wanted to wait and see what the science said. And I wanted any assessment of that science to both focus on benefits and risks. And really, this committee was focused on really only risk. So I chose not to do that. That being said, I think that people across the spectrum are actually interested in preventing drug poisoning deaths and preventing harm from drugs. And so, our research has been presented to current people in elected office in Alberta. When they reach out, we are always encouraging, our staff and students to engage. I engage when I get reached out to as well. So it's not, I would say we're not ideologically motivated. Obviously, we focused here very much on harm reduction, on a novel practice. But that being said, we are so pro recovery and so pro anything that is going to improve someone's health. And if they make that choice for themselves and they're moving in the right direction of health, that is amazing. And so it's actually kind of a false dichotomy to say, some people are harm reduction and some people are treatment or whatever. That is not grounded in reality. The reality is we want to do what works for the person in the moment to not die and then to achieve better health in the long term.
Yeah, I would just add also, it's not ideological to be critical of an institution in power that is implementing harmful policy.
Thank you. Another question in the chat is, are there any policies or interventions that the current government has put into place that are helping to positively address the current crisis?
Yeah, there's one that comes to mind for me that's new from the community perspective. There's something called the GAP program that does provide 4 months of funding for Suboxone, Sublocade, and Methadone that is attached to people's health cards. So there's no application for medication coverage. There is no lengthy wait 6 weeks and we'll see if you're approved. It is immediate. You can go to the pharmacy, you can pick it up. I do think it needs to be longer, but the first 4 months getting that covered for OAT has been really helpful in the community, definitely.
Yeah, and I think more generally, the provincial government has made a strong effort to expand access to opioid agonist treatment. Back in 2016, 2018, we were really starting to deal with this. we had a huge problem with a lack of prescribers and a lack of access to prescribers for Suboxone, methadone, other kinds of opioid agonist medications. And through the VODP, they have really decreased access barriers for people to initiate on those treatments. There's been a strong attempt to connect people to treatment in corrections, which is a huge issue. And I think that work has been very positive. I think the recovery communities, I think they're potentially quite beneficial, especially for people who are using alcohol or stimulants, because we know that there's not a lot of excellent, like evidence-based effective treatments for those conditions. And so again, though, I would like to see like the outcomes before I kind of reserve judgment. But I think generally speaking, investing in mental health, investing in substance use interventions is very positive. And certainly this government should be credited for how much funding they've been willing to allocate to the issue of mental health and addiction. You know, it's a huge burden of disease across the population, and typically, historically, it's very underinvested in, and they are trying to bring it more like towards parity. And I think that's quite commendable. Where those investments go, though, and whether they're guided by evidence, I think we're still sorting some of that out.
Hey, a follow-up to that in the chat is, how do we move beyond the highly polarized attitudes to substance use in which we find ourselves in this province?
Well,
I mean,
do you want to try that? That's the $1 million question, I think.
yeah. And it's not just this province.
Yeah, and it's not just Alberta. Yeah, you know, I think, like, again, I would just say back in 2016, 2017, 2018, when this was like just emerging as a serious issue, we saw quite a bit of cooperation across parties. Even in the US, there was a lot of bilateral cooperation across the Democrats and Republicans. And, you know, I actually went on a State Department sponsored tour to learn about their opioid crisis response under the Trump administration. So there was quite a bit of cooperation. I think we can get back there. I think we really have to we can't use this as a political issue. Like, I understand people want to win elections. They want to, you know, increase their support. But unfortunately, people who use drugs have become a target of political activities that are designed to instill fear and misunderstanding in order to win political support. And I think we have to call that out when we see that on any side, not like, you know, anyone that's trying to use this issue as a part to support partisan gain, I think is doing a disservice generally to this. This is a public health issue. We need to come together and address it as a collective. And, you know, it's always going to be controversial. Substance use imbues a lot of moral debate, but the reality is, you know, people are dying. And I think if you look at the polls, most Canadians know someone that has died. Like, this is an extensive crisis contributing to substantial premature mortality. And even if you just care about economic productivity, you should care about this issue because it's impacting that significantly too. So yeah, I'm not sure what else to say. I think also we try really hard to do education, like educating the next generation of clinicians, obviously, but then also, you know, I'm increasingly trying to move into the undergrad space and just share information about substance use so that people have a reality-based understanding of these concepts and can decide for themselves where they think, you know, we should be investing. And I actually think when people have the information in front of them, they typically do have reasonable opinions about what we should be doing and take a pretty pragmatic approach.
I'll ask one final question along the education front. Patty, you mentioned, and what was highlighted in red is to insulate medical education was part of the report. I was just wondering if you could comment further on that.
So that recommendation in the final report, it came out of the idea that in the early 2000s, there was pharmaceutical companies who would come into medical schools and do presentations on how to prescribe, you know, OxyContin is a big one that we always think of in Purdue. And so the idea was that historical fact was invoked numerous times to explain current trends that they were seeing, even though I didn't go to medical school, but I understand that's less the case, or if not the case anymore. But the idea that the government has a role in inserting itself into medical schools and guiding that education was the gist of that recommendation. I don't know if you want to say.
Yeah, I think just like, again, it's targeting one specific issue. Like, I think it's great to not have conflicts of interest in medical education, and we should certainly be having robust policies and procedures that limit them. But again, just targeting one area and saying that, in this instance, like pharmaceutical companies are being nefarious. Like, I don't think that that's a fair assessment, and I don't think it's particularly helpful. So yeah, that was probably just not so much based on current practice. Yeah, but it's not a bad, but I think also, we've seen like the colleges, the schools of medicine, the faculties, committees across Canada are addressing that issue too, right? And so that recommendation kind of undermines the work that is ongoing.
I'd like to thank very much Dr. Hyshka and Patty Willson for this great presentation. Thank you.